Good morning, good evening, and good night to everyone from across the globe that's joining us for this edition of the EIOC Journal Club. Today, we'll be discussing the evolving paradigm of using and integrating immunotherapeutic agents within the realm of patients with non-small cell lung cancer, looking at it from a spectrum of perioperative to neoadjuvant to adjuvant to metastatic settings. And I'm pretty sure today's discussion will have a flavor for everyone's questions and answers out there in the community. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the very sunny, very warm, very hot, and very safe United Arab Emirates. And today we're joined by some spectacular faculty, both regionally as well as internationally. So I will allow them to introduce themselves. So Francesco, maybe you can introduce yourself.
Good morning and good evening to everyone. And I'm Francesco Passiglia. I'm a thoracic oncologist at University of Turin in Italy, and I see lung cancer patients in my practice, and I conduct also clinical research in lung cancer. A pleasure to be here. Thanks for the invitation. Thank you.
Dr. Aref.
Yeah, hi everybody. Aref Chehal, medical oncologist, Sheikh Shakhbut Medical City, Abu Dhabi.
Hassan Akil. Is he here? Maybe
Yes, I'm here. My name
okay.
is Dr. Hassan Akil. I'm a medical oncologist in Pharmaceutical Corporation in Qatar.
Maroun.
Yes, I'm Maroun El Khoury. I'm a consultant medical oncologist in Dubai and Shaheenah's partner in crime.
Absolutely. He's just down the road from me. And Dr. Farooq Latif.
Assalamu alaikum. Good evening. Dr. Farooq Latif, consultant medical oncologist, Dubai Hospital, Dubai Health.
So thank you all for joining us. Can we put the agenda up, please? So we're going to start off with a lecture that Francesco is going to present to us, actually looking at immune checkpoint inhibition across the lung cancer continuum, looking at it from perioperative intent all the way to the metastatic setting. This will be followed by a very, very intense question-answer/panel discussion that I'm sure will light up everyone's fire. So Francesco, take it away. You can share your slides.
Of course. Do you see it? Is okay?
Yes, we can see it. We can see it.
Perfect. Thank you. So again, good morning and good evening to everyone. And thanks for the introduction and for the kind invitation to this meeting. It's a great pleasure for me joining all of you, even if only virtually. Hope to see you also in person in the near future. Well, in the next 45 minutes, I will present about the evolving landscape of immunotherapy in lung cancer with a particular focus on tislelizumab data. So we will rapidly review about the mechanism of action and then the rational trials, and we will discuss the results in the context of other therapeutic options available both in the early stage and in the metastatic disease. So let's start with some biological background. You know very well the mechanism of action of monoclonal antibodies blocking the PD-1, PD-L1 checkpoint, allowing T cells to maintain or restore, in some cases, their effector function at the tumor site. However, the binding of the FCR portion mediates cross-linking between the PD-1 positive T cells and the FCR positive macrophages, potentially inducing macrophages to phagocytize the PD-1 positive T cells and finally reducing anti-tumor responses. In this regard, tislelizumab is a humanized IgG4 monoclonal antibody with high affinity and binding specificity for PD-1 receptor that was designed to have minimal binding to the FCR on macrophages, so preventing T cell clearance at tumor sites. Tislelizumab is also characterized by different binding orientation and kinetics, definitively leading to a complete blockade of PD-1, PD-L1 interaction as compared to a partial blockade we can obtain with other checkpoint inhibitors, PD-1 inhibitors like Nivo or Pembro. And finally, in preclinical models, as you can see here, tislelizumab demonstrated also a high target affinity and slow dissociation rate from the PD-1 receptor, and its half-life is approximately 30 to 80-fold longer than reported for pembrolizumab or nivolumab, so providing a strong rationale for an increased anti-tumor activity. Now, if we look at the clinical data available in lung cancer, we can see we have today 5 different positive randomized studies entirely conducted in Asia, including either early stage and advanced non-small cell lung cancer, as well as extensive stage small cell lung cancer, all reaching their primary endpoints and finally leading to the inclusion of tislelizumab among the recommended options for the treatment of lung cancer patients by ESMO guidelines. And the ESMO magnitude of clinical benefit score of tislelizumab is quite comparable to other competitors. As you can see here, the NCBS is reported to be A for the early stage resectable disease, between 4 or 5 for the advanced non-small cell lung cancer, and 2 for extensive stage small cell lung cancer that we will not address today. Finally, this is the regulatory approval picture for tislelizumab updated on April 26, showing that the drug has already obtained different indication in upper GI tumors and head and neck cancer by both NCCN and EMA, FDA, and EMA, while as regards the lung cancer indication, these are currently approved only by EMA. Now, moving through the data, let's start with the early stage resectable non-small cell lung cancer, where the updated ESMO guidelines, as you know, recommend molecular testing at the time of diagnosis in order to identify oncogene-addicted patients, meaning today mainly EGFR and ALK positive disease, but likely including soon also RET in the near future based on the libretto data presented at ASCO a few weeks ago. And we know that for these patients, the surgery upfront followed by adjuvant TKI is the current standard of care. On the other hand, if we look at the non-oncogene-addicted patients, as you know, neoadjuvant or perioperative chemo followed by surgery is the current standard of care. And this clinical recommendation is based on the results, on the positive and consistent results of 6 different randomized clinical trials comparing the efficacy and safety of different PD-1, PD-L1 inhibitors versus placebo, both in combination with histology-driven platinum chemotherapy as neoadjuvant only or perioperative treatment for patients with stage 2 and 3 resectable non-small cell lung cancer. All these studies demonstrated a significant increase of pathological responses from the addition of PD-1 inhibitors to platinum chemotherapy, with a pathological complete response ranging, as you can see here, from 20% to 40% in the rational study with tislelizumab. We will discuss later more in details. And the addition of PD-1 inhibitors to platinum chemo translated also into a significant event-free survival benefit, with a consistent and comparable hazard ratio reported to be around 0.60 across all these studies. Now let's do a brief focus on the Rational 315 study comparing the efficacy and safety of tislelizumab versus placebo, both in combination with histology-driven platinum chemotherapy as perioperative treatment for patients with stage 2, 3A resectable non-small cell lung cancer without EGFR and ALK oncogenic alterations. This study, as you know, was entirely conducted in China, and the co-primary endpoints were the major pathological response and the event-free survival. As you can see here, the baseline patients' characteristics were well balanced between the two treatment arms, with most of the patients being male, smokers, and squamous histology. The Rational 315 met both co-primary endpoints at the final analysis based on almost 2 years of follow-up, showing a significant and meaningful improvement of both major pathological responses, as you can see here, 56% compared to 15%, and event-free survival with hazard ratio 0.58 in the overall PD-L1 unselected population. Now, if we look at the forest plot of the study, we can see that the event-free survival benefit in favor of tislelizumab was confirmed across all pre-specified subgroups, including stage, smoking status, and PD-L1 expression levels. And this is a recent exploratory analysis presented at the last European Lung Cancer meeting in Copenhagen a few months ago, showing a significant correlation between the residual vital tumor and the event-free survival benefit. So confirming once again what we have observed and learned from other randomized trials in the same setting, and so the prognostic role of this biomarker beyond pathological complete response in stratifying those patients who derive the most clinical benefit from neoadjuvant chemo. The addition of tislelizumab to platinum chemotherapy was associated also with a significant improvement of relevant secondary endpoints, including pathological complete response, as you can see here, 41% in the tisle arm versus 6% in the chemo alone arm, and overall survival with hazard ratio 0.65 and a 4-year OS rate of 72% in the tisle arm versus 62% in the placebo arm, respectively. Tislelizumab plus chemotherapy was generally well tolerated with a manageable safety profile and no differences in terms of both any grade and grade 3 and 4 treatment-related adverse events between the two treatment arms. As expected, the rate of immune-related adverse event was higher in patients receiving tislelizumab versus chemotherapy, but most of them were reported as grade 1 and 2. Finally, if we look at the patients' reported outcomes, we can see a significant and meaningful improvement of clinical symptoms like cough or chest pain from the baseline to cycle 3 of neoadjuvant chemo for patients receiving tislelizumab versus placebo, so supporting a positive impact of the treatment on patients' quality of life, that it's also a relevant endpoint in this curative setting. So what is now the key clinical significance of the Rational 315 study in the context of other randomized studies exploring perioperative chemo strategies in the early stage resectable non-small cell lung cancer? I summarized here the patient's characteristics coming from the main randomized studies in this setting. And first of all, we can highlight some differences in the study population. As you can see here, the Rational 315 is the only one including 100% Asian population compared to 30 to 40% in other randomized studies. Then we have a lower number of females and no squamous histology, but a similar rate of never smoker, quite similar to that reported also in other randomized studies. And finally, it's important to note that the Rational 315 is the only study including only stage 3A, so lacking stage 3B patients in the study population. And this is the reason why the rate of N2 disease was a bit lower compared to the other randomized studies. This table summarizes the study's results, looking at the efficacy of chemo across randomized studies in the perioperative setting and allowing us to make a sort of indirect comparison between drugs, showing a higher major pathological responses and pathological complete response obtained with tislelizumab as compared to other checkpoint inhibitors in the same setting, while if we look at event-free survival benefit reported in the Rational 315, this is quite comparable to that observed in other randomized studies. Then the Rational 315 and the Keynote 671 are the only two randomized studies today reporting also a significant overall survival benefit at the final analysis, so showing a similar consistent results in terms of both hazard ratio, median survival, and long-term survival. The differences in the safety profile is mainly ascribed to the different reporting of adverse events between studies, so very difficult to compare this data. Indeed, if we look at the treatment discontinuation, this is absolutely comparable across studies. Now we know that all these randomized studies showed that the surgical outcomes were improved with the addition of PD-1 inhibitors to platinum chemotherapy, and we know that around 15 to 20% of the patients did not receive surgery, while if we look at those patients receiving surgery, we have 90 to 95% of R0 resection, less than 10% of pneumonectomy, and a very low rate of postoperative mortality, reported to be around 1–2% across all these studies. Finally, in order to overcome the main limitation of the Rational 315 that, as we said before, was entirely conducted in China, we planned and conducted this transportability analysis of the Rational 315 to the European population based on the real-world patients' characteristics and outcomes reported in two different adjuvant and neoadjuvant published cohorts. And as you can see here, after adjusting the trial population to make them more similar to the European patients, the statistical analysis showed us that the predicted benefit in favor of tislelizumab for the target European-like population were comparable to those observed in the Rational 315. So definitively supporting the efficacy of this agent also in non-Asian population. So in conclusion, the neoadjuvant and perioperative chemo is the current standard of care for stage 2 and 3 resectable non-small cell lung cancer based on the positive and consistent results of different randomized clinical studies. Today, the Keynote 671 and the Rational 315 are the only two randomized studies showing also a significant overall survival benefit, so supporting the role of tislelizumab and pembrolizumab as preferred option for clinical use. Open question remains, like the contribution of adjuvant immunotherapy after neoadjuvant chemo, the definition of standardized resectability criteria, as well as the role of chemo induction in stage 3 unresectable disease we don't have time to address today. We have promising prognostic biomarker like pathological complete response, residual vital tumor, and ctDNA clearance that will likely improve our clinical decision-making in the future, while the NGS biomarker testing and the multidisciplinary discussion remain mandatory today for all early-stage lung cancer patients in order to personalize the treatment decision in the real world. Moving now to the metastatic disease, these are ESMO guidelines reporting the treatment algorithms for non-oncogene-addicted advanced non-small cell lung cancer with single-agent immunotherapy recommended for patients with high PD-L1 expression and chemo-IO combination available regardless of PD-L1 levels for this population. This indication of PD-1 inhibitors monotherapy in PD-L1 high patients is based on the positive results of 3 randomized studies showing a consistent overall survival benefit favoring single-agent immunotherapy versus platinum-based chemotherapy in PD-L1 higher than 50% selected advanced non-small cell lung cancer patients, with around 30% of the patients alive at 5 years across all these studies. If we look at the chemo-IO combinations, these are the main randomized studies showing a significant superiority from the addition of PD-1 inhibitors to platinum chemotherapy in the PD-L1 unselected population. As you know, different drugs, different regimens. We have PD-1 plus 4 cycles of platinum chemotherapy in the Keynote and in Power Lung studies. We have the PD-1 plus CTLA-4 plus 2 cycles of platinum chemotherapy in the 9LA study. But finally, we get similar long-term survival with around 20% of the patients alive at 5 years across all these randomized studies. If we look specifically at the PD-L1 negative population, we know this is a different subset, different biology, and in absence of direct comparison randomized studies, this individual patient data meta-analysis, including almost 1,000 patients from all published randomized studies, has recently demonstrated a significant benefit in terms of overall survival from the addition of anti-CTLA-4 to the PD-1 chemo combination, supporting the potential role of dual checkpoint blockade as preferred option in this population. So again, how does tislelizumab compare with all these agents that are already available and approved for the clinical treatment of metastatic non-small cell lung cancer? Let's take a look again at the RATIONAL study, starting with the RATIONAL 307, that is a phase 3 randomized clinical trial aiming to compare the efficacy and safety of tislelizumab in combination with either carboplatin paclitaxel or carboplatin nab-paclitaxel, both compared with carboplatin paclitaxel as control arm in the first-line treatment of patients with advanced squamous non-small cell lung cancer. The primary endpoint, as you can see here, is progression-free survival. The baseline patients' characteristics are well balanced between the 2 treatment arms, with most of the patients being males and smokers, while we have a very low rate of brain mets at baseline. As you can see here, brain mets are reported to be around 2% in both treatment arms. If we look at the study results, the RATIONAL 307 met the primary endpoint at the final analysis based on almost 2 years of follow-up, showing a significant improvement of progression-free survival with the addition of tislelizumab to platinum-based chemotherapy. Hazard ratio is 0.45 for paclitaxel and 0.43 for nab-paclitaxel arm, respectively. If we look at the forest plot of the study, we can see that the PFS benefit in favor of tislelizumab was confirmed across all pre-specified subgroups, including disease stage and, more importantly, PD-L1 expression, with a magnitude of benefit confirmed also in the PD-L1 negative disease. And the addition of tislelizumab to carboplatin paclitaxel was associated also to a significant improvement of overall survival, with hazard ratio 0.69, while the OS difference do not reach a statistical significance for the arm B, including nab-paclitaxel, where the hazard ratio is 0.84. Again, if we look at the forest plot for overall survival in the arm A with carboplatin paclitaxel, we can see that the overall survival benefit associated with tislelizumab was confirmed across all pre-specified subgroups, with the same magnitude of benefit maintained also across different PD-L1 levels, including PD-L1 negative disease. So similar data in terms of PFS and OS, at least for this experimental arm. And finally, the confirmed objective response rate was significantly higher, and the median duration of response longer with tislelizumab versus placebo, with objective response rate reported to be around 70% in the experimental arms versus 50% in the control arm, and the median duration of responses reported to be around 8 months in the experimental arms versus 4 months in the control arm. Tislelizumab plus chemotherapy was well tolerated with a manageable safety profile and no differences in terms of both any grade and grade 3 and 4 treatment-related adverse events between the two treatment arms. As expected, the rate of immune-related adverse event was higher in patients receiving tislelizumab versus chemotherapy alone, but most of them were reported as low-grade adverse event, neither requiring corticosteroid treatment or leading to tisle discontinuation. Moving now to non-squamous histology, the Rational 304 is a phase 3 randomized trial aiming to compare the efficacy and safety of tislelizumab versus placebo, both in combination with platinum pemetrexed as first-line treatment for patients with non-squamous advanced non-small cell lung cancer without EGFR and ALK oncogenic alterations. Primary endpoint of the study, again, progression-free survival. The patient's characteristics, again, are balanced between the two treatment arms. We can note here around 25% of the patients being females, 40% never smokers, and again, very low rate of brain mets at baseline, reported to be around 5% in both treatment arms. If we look at the study results, at the primary endpoint, the Rational 304 showed a significant improvement of progression-free survival with the addition of tislelizumab to platinum-based chemotherapy, hazard ratio 0.63 in the overall PD-L1 unselected population. However, if we look at the subgroup analysis for the PFS, we can see that the PFS benefit of tislelizumab was limited to the PD-L1 higher than 50% subset, with hazard ratio reaching 0.30 in this subgroup of patients, while the overall survival differences did not reach the statistical significance in the PD-L1 low and negative population. As regards the secondary endpoints of overall survival, the study failed to show a significant survival benefit in the overall PD-L1 unselected population, while showing a statistically and clinically meaningful OS advantage, again in the PD-L1 higher than 50% subgroup, with hazard ratio 0.38 in this subset of patients, and with 54% versus 30% of the patients alive at 3 years. So this data supported the regulatory approval of tislelizumab plus platinum pemetrexed pemetrexed in this subset of PD-L1 high selected population with PD-L1 higher than 50%. Finally, we can see also the tumor responses following the same trend, reaching 57.8% versus 30% in the ITT population and 70% versus 30% in the PD-L1 high subgroup, respectively. Similarly to the previous study, tislelizumab plus chemotherapy was generally well tolerated with a manageable safety profile and no main differences in terms of grade 3 and 4 treatment-related adverse events. And again, the vast majority of immune-related adverse events were grade 1 and 2, so did not require the corticosteroid treatment or treatment discontinuation also in this study. Now, this table summarizes the main patient's characteristics from the chemo-IO studies starting from squamous advanced non-small cell lung cancer. In this context, we can note that the Rational 307 is again the only study including 100% Asian population. We can note also a lower number of females and a very low rate of brain mets at baseline as compared to the other randomized studies like the Keynote 407, the Checkmate 9LA, and the Empower Lung 3. Looking at the efficacy data, we can highlight a higher objective response rate for tislelizumab plus chemotherapy as compared to other checkpoint inhibitors with all the limitations we know in this kind of indirect comparison. Second difference is a relevant benefit with tislelizumab that is maintained also in the PD-L1 negative population, differently from both pembrolizumab and cemiplimab that we know lack a statistical significance in the PD-L1 negative subset as regards the main endpoint of overall survival. And finally, we can see also a higher long-term overall survival with tislelizumab, with 30% of the patients alive at 4 years versus 20% reported for all other randomized studies. So this data generally support the role of tislelizumab as an effective option in squamous advanced non-small cell lung cancer patients with any PD-L1 expression levels. Moving to non-squamous disease, this table summarizes the main patient's characteristics of the main randomized studies conducted in non-squamous non-small cell lung cancer. Again, we can note some differences in the study population, so the Rational 304, 100% Asian population, lower number of females, but we have a higher number of never smokers, and again, a low rate of brain mets at baseline. Looking at the study results in non-squamous histology, we can make again a sort of indirect comparison between studies showing a higher objective response rate for tislelizumab and a similar and consistent overall survival benefit in the PD-L1 unselected population across all these studies. So the negative results of the Rational 304 in the PD-L1 unselected non-squamous population, as we can see here, is mainly related to an overperformance of the control arm, reaching a median OS of 20 months versus the 10 months of the control arms reported in all other randomized studies. However, if we look at the PD-L1 high subgroup, we can see an important overall survival benefit with tislelizumab reporting a median overall survival of 42 months and a 3-year OS rate of 54%, which nearly doubled the OS outcomes reported with other randomized studies in non-squamous histology. So generally supporting the role of tislelizumab plus chemotherapy as an effective option in the upfront treatment of PD-L1 higher than 50% non-squamous advanced non-small cell lung cancer. Now, based on this promising data, one key clinical question today is about the best treatment for patients with high PD-L1 expression and how to select between single-agent immunotherapy or chemo combinations in the real world. Now, in absence of direct comparison randomized studies, data coming from post-hoc analysis and retrospective studies currently suggest that the single-agent immunotherapy may be considered as an effective and better tolerated option, in particular subgroups, including patients with very high PD-L1 expression, higher than 80 or 19%, smoker population, and if we look at the genomic background, of course, patients with KRAS, STK11, KEAP1 wild-type disease, since this molecular alteration, as we know, drive innate resistance to PD-1 inhibitors, as well as in frailer population who cannot receive platinum chemo, considering the toxicity profile of this combination. If we look at the randomized studies to date, we have just this one that has been recently presented at ESMO, comparing chemo combination versus single-agent immunotherapy in patients with advanced non-small cell lung cancer PD-L1 higher than 50%, setting the tumor responses at 6 weeks at primary endpoint of the study. This is something that maybe we can discuss later. The results of the study were presented at the last ESMO, showing no differences between the two treatment arms in terms of objective response rate, PFS, and OS. But it's important to note that unfortunately, the enrollment of the patients in this trial was closed earlier for futility, so dramatically reducing the number of patients enrolled in the study, so reducing also the reliability of the statistical comparison of study outcomes, and finally, in my opinion, also the scientific value of the trial findings and conclusion. On the other hand, we have the results of an individual patient data meta-analysis that has been recently published in JAMA Oncology a few weeks ago, including about 24 randomized studies testing single-agent immunotherapy and chemo combination in more than 5,000 advanced non-small cell lung cancer patients with PD-L1 higher than 50%, providing a high-quality indirect comparison of these treatment strategies from the methodological point of view, and the results of this analysis show us a significant improvement of all oncological outcomes, objective response rate, duration of responses, progression-free survival, and overall survival in favor of chemo combinations versus single-agent immunotherapy. So currently supporting, in my opinion, the role of chemo combination as upfront standard of care also for patients with PD-L1 high expressor. And we are now waiting for the final results of two ongoing randomized academic studies, which are very close to release the results, and then which probably provide us with a definitive answer about the best upfront treatment in this PD-L1 high selecting population. Now, looking at the future, another relevant clinical question is, can we raise the bar of immunotherapy in metastatic non-small cell lung cancer? Any role for new drugs like ADC and bispecifics in the first-line treatment of this population? And in this context, I think one of the most relevant data presented at the plenary session of ASCO 26 a few weeks ago was the Harmony 6 trial results, showing a significant overall survival benefit from the addition of ivonescimab to platinum chemotherapy in metastatic squamous non-small cell lung cancer, along with a tolerable safety profile, so suggesting this kind of combination as a future standard of care in a clinically selected squamous non-small cell lung cancer population. So in conclusion, chemoimmunotherapy combinations are the current standard of care in PD-L1 unselected, advanced, non-oncogene addicted non-small cell lung cancer, while single-agent immunotherapy is an effective and tolerable option in special subgroups we discussed before, so very high PD-L1 expression, smokers, STK11 KRAS wild-type disease or frailer population cannot be candidate to platinum chemotherapy. Open question remains also in the metastatic disease, like the additional contribution of CTLA-4 inhibitors to PD-1 plus chemo combination in the subset of PD-L1 negative disease, and the clinical and optimal management of immunotherapy resistance. Among the new drugs coming in the clinic in the future, promising and mature data support the role of bispecific like ivonescimab in the first-line treatment of squamous non-small cell lung cancer, while we are still waiting for more convincing data about the role of ADC combo in the first lines. Since I don't know your opinion in this regard, but the OptiTrop study presented at ASCO, we don't have time to discuss today, even if positive, compared with a suboptimal control arm of single-agent immunotherapy, while the chemo-IO combination remains the current standard of care in this population. And finally, we have an increasing amount of data suggesting that personalized IO strategies based on clinical characteristics, tumor histology, and PD-L1 and the genomic profile is the way forward to optimize the clinical outcomes of our patients. This is my last slide, and I thank you for your attention. Thank you.
Thank you. That was a fantastic lecture giving us a deep dive into IO therapies right from perioperative all the way to the metastatic, and some very interesting data looking at the newer immunotherapeutic agents. So while I pull up my slides, it will begin the fireside chat. Does anyone have any questions before we start?
Thank you very much, Professor, for your very interesting, presentation and highlights and review. There was, two data about pathological complete response. One is 56% and one is 41%. What is the difference between that? Was in squamous or non-squamous or something different? I don't know.
Do you mean, I'm sorry.
There is, in the neoadjuvant set, in the perioperative setting, there is one slide showing pathological complete response 56%. Then you showed another slide 41%.
No, this one 56 is the major pathological response. 41 is the complete pathological response. This is the difference.
And we'll be talking about that in detail. So
it's
thank
clear? Okay.
Yes.
Okay.
Thank you, Dr. Francesco. Some very interesting data. So you presented, sorry, yes, you can all see my slides, right?
Yeah, I cannot see.
You cannot see?
Yeah, I see now. Yeah.
All right, so
yeah.
Everyone else can see my slides, correct?
Yes.
Okay. So what you see on the slide over here is the use of perioperative immunotherapy, and just looking at that pathological complete response versus major pathological complete response. And you can, go back here. And when you look at, let's just look at major pathological complete response, which are the orange bars that you're seeing over here. It does vary across trials, But what strikes me is in the rationale 315, you're getting a very high major pathological complete response of almost 56%. Now, I really like this slide that you presented, Francesco, looking at just some of the differences between the key randomized studies. Now, you very rightly pointed out that only 9% of patients enrolled in these studies enrolled in the rationale 315 was actually female. How do you account for this? I mean, yes, ethnicity-wise, this trial was conducted in China, but only 9%. You would expect at least the female to male distribution would be similar. So, what are your thoughts here?
Yeah, this is an interesting question. Also, because this is something we have also in the metastatic non-small cell lung cancer studies. Very low rates of females population, including in clinical studies across stages. I don't think it's something related to the epidemiology of lung cancer that we know is increasing in female patients, especially when we talk about Asian population. I think it's something related to the disparities, I think, in the clinical trial access we have and we are still discussing across different countries around the world. This is an important topic you highlighted here, and I think these trials provide us the opportunity to discuss and to highlight this relevant topic, because we need to work in this direction to increase access also of female to clinical trials. This is my opinion about that.
And then again, Francesco, the question is directed to you because you obviously know how these trials were actually conducted. The rationale 315, as you rightly pointed out again, restricted its cohort of patients to those patients with stage 3A. So my question is, why did it restrict it to stage 3A compared to the other perioperative and neoadjuvant studies that took a wider gamut of patients, including stage 3B, including stage 2 patients? So why restrict it to stage 3A?
I don't have the answer to this question. I agree this is a kind of relevant difference compared to the other studies. Probably this also introduce a kind of bias in the prognosis of the included population, because we don't have stage 3B. We have also some differences in the study population, so it's probably a better prognosis population, the population we included in the rational 315. But I think the difference we get in terms of pathological responses that you showed also in the slide before is not only ascribed to the difference in the study population. I think there is also something in the mechanism of action of the drug that is quite different from the other PD-1 inhibitors that may contribute also to this kind of difference in terms of study results.
Okay, and then and this is a question that will come up later on, but I see that the shortest follow-up actually in amongst all the studies was obviously the rationale 315 at a follow-up of 22 months. Now, this is very interesting. Like you pointed out, the pathological complete response rate is the highest with rationale 315 at 40%. Major pathological complete response, again the highest with rationale 315 at 56.2%. And as you mentioned, these patients actually enrolled in this study had an overall survival advantage, like what we saw in the keynote trial compared to the Checkmate 770 and the Asian study. So my question now to Dr. Khoury, how do you account for this? How do you account for the early, because remember, the follow-up also was very short. So we're seeing an early overall survival advantage compared to the longer follow-ups that we've seen with Asian and Checkmate 770. I mean, even in the keynote 671, we saw an overall survival advantage. It was not as early as what we're seeing in the rationale 315. So how do you account for this?
I think it has to do with the pharmacokinetics, like Dr. Francesco told us, show us the first slide. I think I'm impressed by this dissociation, like 80-fold, and maybe I don't know. I'm not a pharmacokinetic guy, but I think this is where the answer is. And maybe I mean the blockage is more sustained over time And then that's why you are seeing this difference early on. I'm not sure. I think it's pharmacokinetics related.
Farooq, what are your thoughts here?
I think it's down to the efficacy of the drug, really, quite significantly higher complete response rate as well as a higher major pathological response. So I think it's to do with that. And obviously, we know with the immune checkpoint inhibitors, the responses are generally maintained. So I think this may have something to do with the early overall survival benefit, even with the shortest follow-up of the study.
So, Francesco, I'm going to play devil's advocate here. I actually completely agree with Maroun and Farooq. But could it be that we're seeing such an early overall survival advantage because of the fact that it had such a clean cohort of patients of only stage 3A versus the wide gamut of patients that were seen in Agent and Checkmate 772 that could have influenced when you were going to see that overall survival advantage?
Well, first of all, the median follow-up report in the previous table is related to the final analysis. I mean, the first analysis of the study, the pre-planned analysis. But then we have also an updated overall survival analysis that I showed you during the presentation, confirming also this long-term survival benefit is maintained and confirmed, or also a longer follow-up. This is quite comparable to the keynote follow-up and the keynote study results. As I said you before, of course, there may be something in the difference, something related to a better prognosis of the study population regarding the stage, regarding the clinical characteristics of the patients. We don't know the impact of the Asian ethnicity on the efficacy of immunotherapy. We don't have evidence which support a different effect of immunotherapy in Asian versus non-Asian, because the immune system is the same, the mechanism of action of the drug is the same. There may be some differences related probably due to the HLA system that is genetically different between different ethnicities. So there may be something different in the immunogenicity of the tumor or in the presentation of the antigens, but we don't have enough data to support this kind of hypothesis. So I think at the end there is something in the drugs that is probably likely more effective than other PD-1 inhibitors.
Dr. Aref, what are your thoughts here when you look at the OS data for these trials? Does it influence your decision as to what you're going to use in the clinic on Monday if everything was available?
Yeah, I think that data is highly impressive with the major and the complete pathological response rate that is the higher of all among immunotherapy available. That's why it drew my attention and I asked about it. Definitely, when you have an overall survival in advanced stage non-small cell lung cancer, this is a great achievement, and especially when you see it early. Although we cannot compare data to data or study to study, as everybody highlighted, the type of population, ethnicity, genetics, probably stage of disease. But however, this is and give you a hint that this drug is effective, and probably we need to try it, or we can make a study about our populations as studied in European and show like it is effective there. We can do it here also. Thank you.
Francesco, if I could ask the question, could it be that the high PCR that we're seeing associated with the use of immune checkpoint inhibitor plus chemotherapy in the rationale 315 is what is driving that early overall survival advantage? Because you've actually shown that if you get a PCR, you do better. And the drug is managing to give you a higher PCR rate of 40.7% and an MPR of 56.2%. So could that be driving the spectacular, I think, overall survival that we're seeing in these patients?
Yeah, I agree with you. All these clinical trials are sending us the same messages that the complete and the major pathological response are early surrogates and reliable surrogates of overall survival advantage we can get with this kind of chemo-IO combinations in the neoadjuvant setting. I liked also the residual vital tumor analysis that has been presented at the LCC meeting, showing us that we can look beyond the pathological response, beyond the complete and the major pathological response to stratify, to better stratify our patients. And this makes sense when we discuss about the potential impact of the adjuvant treatment in the context of this perioperative treatment. But definitely I agree with you that the impressive benefit in terms of pathological response is probably the major driver of the meaningful overall survival advantage we get in these studies.
All right. So,
Can I ask a question?
yes, please go ahead.
Quick question. Thank you. Quite impressive efficacy. When we look at the toxicity profile, it's 70+% as compared to 30 to 40% with all other immune checkpoint inhibitors. I know you mentioned that this is to do with the reporting. Is it really to do with the reporting, or is there something else going on here? Do we have the details of the grade 3 toxicity events?
Yeah, we have.
Because 70% sounds quite high.
Yeah, we have the details, and I look very deeply to the details, but it's a completely different reporting system. We don't have the treatment related. We have a different system to report the adverse event in the rational 315. So the higher rate of adverse event is only related to the different systems of toxicity reporting in these studies. Indeed, if you look at the treatment discontinuation, that is something that is standardized. This is absolutely similar. This is absolutely the same. So a higher toxic combination should be associated with a higher incidence of treatment discontinuation. But when you look at the discontinuation, the drug discontinuation, this is absolutely in line with other studies.
All right. So in your conclusion side, Francesco, you do mention some of the challenges, which includes what is the contribution of the adjuvant phase and how do you manage those non-responders? So what do you do in your clinic? Do you actually give adjuvant immunotherapy? Because I think we have most of the trials are looking at perioperative versus continued with the adjuvant. But we do have the Checkmate trial that also has an overall survival advantage to just giving neoadjuvant immunotherapy with nivolumab. So how do you discern, if I may ask the question, between giving neoadjuvant versus perioperative?
Well, this is the question. I mean, I think everyone in our clinic, whenever patients with early stage resectable, there is something to discuss about neoadjuvant only versus perioperative treatment, because we don't have direct comparison trial between showing us that the additional contribution of adjuvant immunotherapy after neoadjuvant chemo IO. However, we don't have also data that clearly say us that the adjuvant immunotherapy does not work after neoadjuvant chemo IO. So currently in my clinic, the only subset of I recommend perioperative chemo IO in all my patients, and I usually do also the adjuvant phase of the treatment after surgery. The only subset of patients which I discuss for a treatment de-escalation, so omitting the adjuvant phase, is probably the subset of patients who obtain a complete pathological response after neoadjuvant chemo IO. We are quite confident that these patients are probably cured by neoadjuvant chemo IO. So probably in these patients, I discuss the opportunity to stop the treatment after surgery. But today, with a few evidence available in the literature, I think in my clinic, I continue immunotherapy also in the adjuvant phase.
Dr. Hassan, let me ask you a question here. Rationale 315 delivered an event-free survival hazard ratio of 0.58 and an MPR of 56.1% versus the 15% with chemotherapy alone, alongside data from the Keynote 671, Checkmate 770, and AGEN, when you have now 4 perioperative regimens, all show somehow comparable results. So what should drive the choice at your MDT? I'm asking you the multi-million-dollar question here. What should drive the choice at the MDT table? Should it be the depth of pathological response, the neoadjuvant only versus the full perioperative debate, or the toxicity that's associated with each of these perioperative regimens? So how do you decide what it is that you're going to use?
So thank you so much for this question. And as you said, it's $1 million question. I do believe in our region, and even if in your hospital, in our hospital, we have an excellent MDT. And especially in lung cancer, studies have shown patients who are treated via MDT discussion, they have a better survival rate, which we are pretty lucky to have it here in Qatar and also in other Gulf areas, which is a very important one. This question is a tricky question. What I do believe that it's a combination of all. We are very lucky to have our expertise on everything, and we have a very good surgeons that will help. So it's an individualized line of treatment. I do believe it's different from person to person, from treatment to treatment, even patients. So we are speaking a 30-year-old patient treatment. It's different, a little bit different than treatment of a 75-year-old patient, and how we attack those ideas. So I do believe it's a combination of everything, and it's individualized to each patient plan of care and how we are treating them. But يعني, at the moment also, from my opinion, I do believe that the depth of the pathological response is the main character. But as I told you, it's individualized between patients, and we are lucky to have this luxury that we can discuss every single patient in different line of treatment.
So, Francesco, before we go to the second question, how do you choose between all these regimens? If everything was available and of equal cost, how would you choose?
Well, I think the methodology matter, and when we talk about evidence-based medicine, we should take into account that we have the overall survival results available, showing a significant benefit in terms of overall survival only from 2 of these randomized studies. I mean 3. That is Checkmate 816, neoadjuvant only treatment, Keynote 671, and then the Rational 315. So taking this in mind, my choice probably is, as I said you before, between neoadjuvant only and perioperative chemo. And as I said you before, my standard today is perioperative chemo, except specific situation when I get a pathological complete response, I can de-escalate the treatment. So my choice in the clinic today is between Pembro and Tisle, I mean, because I think we should consider the overall survival data supporting these drugs as a standard of care in our clinic.
So, Maroun, let me ask you this question. I've already asked Francesco this question. What drives you to use perioperative versus neoadjuvant? Is it PCR? Have you ever thought about de-escalating the use of adjuvant immunotherapy? And what sort of factors help you decide whether you're actually going to go ahead and give that adjuvant chemotherapy bit?
Yeah, depending on how I treat patients, I follow studies. If I'm going to use Pembro, then I follow the Pembro data. If I have to use Tesla, I will continue. I mean, I will follow what the study that I'm sticking to. Of course, I mean, complete pathological responses, and we learned from other malignancies that this will drive a discussion with the patient about the question mark of the benefit of adjuvant treatments. Also, it has to do with the tolerability, affordability, all these. But in general, I tend to follow, adjuvant if I started the patient on on a perioperative trial.
Okay, let's go to the next question. tislelizumab, I can never pronounce this, lung trials enrolled predominantly Chinese population. I would say that this question is actually worded wrong. It actually enrolled exclusively Chinese population. The Nicola Giria World Lung Cancer Conference 2025 meta-analysis showed near identical first-line overall survival hazard ratios in Asian versus non-Asian patients. You can see the hazard ratio is 0.7. We also saw in the transportability analysis that Francesco just presented that, it's very similar to what we're looking at in terms of the European data. So is checkpoint inhibition in non-small cell lung cancer now considered to be a class effect? Does it matter where patients are being enrolled? Dr. Aref, maybe you can answer this question. Does it matter to you that the rationale studies looked at Chinese patients in terms of extrapolating that data and using it in our Middle Eastern population?
Well, to be honest, when first TKI gefitinib approved in EGFR mutant was studied in Chinese populations, Asian populations, and later on adapted all over the world, and I think it's working. And later on, many other TKI came. So being studied in Asian population is not an absolute contraindication to be used in our populations, but I think the data has to be replicated somewhere else. Probably, because some other also Chinese medicine, they are nowadays including more and more Western patient or Caucasian patient in their study. But this, being in medical oncology field for more than 30 years now, and I think I have no limitation if it is studied there. Probably if it gets the EMA approval or if FDA approval, I think everybody is, can use it. But of course, whatever mentioned even in, when you have the keynote, the checkmate, when we try it on our patients, sometimes we see different toxicity, different response. So probably we need to try this medication and see our experience. Thank you.
And Dr. Farooq, what are your thoughts here? I cannot see him. So maybe, there, I can't hear him.
Yeah. Can you hear me? Yeah. I believe it's more to do with the biological rationale and class effect rather than a geographic distribution. I think for decades we have seen clinical trials coming from Europe and Western countries, and we have used them in the Asian population. So to me, it's not really an issue at all. I'm comfortable using this. Yeah.
All right. Now, in the rationale 315, enroll stage 2 to 3A and excluded stage 3B, unlike the keynote 671 and the checkmate 717. Now, we have touched upon this earlier on, but Dr. Hassan, do you think that this is a constraint in terms of the generalizability? Would you use rationale 315 in a patient with a stage 3B if they presented to you in the clinic tomorrow?
It's included in the 3B. I would a little bit be hesitant right now to have it to give for stage 3B patients, even though the data of the other ones are doing that. This is mainly this one, but I might consider that. But when I go with the new guidelines and doing that, using the more familiar medicine that I'm using with the IOs, I would lean on it. I do believe that I need to use it on earlier stages patients first before deciding going with using it in stage 3B resectable patients.
Francesco,
Nice question, Shaheenah. I thought, if I'm not mistaken, I understood that 100% of patients were 3A on rationale 315, right? No?
No, 2 to 3A.
2 to 3A.
But how many patients had 3A versus 2? Francesco?
Not include 3B only.
Do you mean the percentage of the stage 3?
Yeah, percentage, yes.
I will check. I have the slides here, so I will check because I don't remember. even if I study the topic, but
And also the same, and stage 3B, the resectable stage 3B is a minor population, I think, resectable stage 3B, right?
Yeah, is stage 3B across all other studies around 15 to 20%, okay, of the stage 3. I mean, the vast majority are stage 3A anyway. I don't have this the percentage of stage 3A in the rational 315. Yeah, but the vast majority of the stage 3, I mean, 70% of the stage 3, 75% of the stage 3 are stage 3A across all these study, except for the rational that are 100% stage 3A. But I think
Yes, so
I
the
agree.
rational is 100% stage 3A. That's what I'm saying. So the rational is 100% stage
If
3A, right?
talking about stage 3, but all the study included also the stage 2. Okay.
Oh,
All
from
right.
stage 3, it's okay.
All right. So,
So it's
Francesco,
about 60 versus 40. So 60, I think majority stage 3A and 40% stage 2. That's what I could see.
going back to Francesco, if you
Yeah.
had in your clinic that's stage 3B, would you be happy to extrapolate the results of using tislelizumab in that particular patient?
Yeah, I don't see any issue about the to extrapolate and to treat these patients with tislelizumab. I think what is important from the clinical point of view in stage 3 patients is discussing in the multidisciplinary team all these cases to evaluate resectability upfront, because sometimes we treat these patients with chemo and then these patients are not good candidates for surgery, and they receive the radiotherapy sequentially after chemo, and we have several issues with efficacy and toxicity, and we miss the opportunity to make concurrent chemoradiation up front in this population. So it's important. I think the main issue in the stage 3B is not discussing between one checkpoint inhibitor or another. No issue to treat this patient with TISL, but the main issue is discussing all these patients in the MDT in order to assess the resectability up front, because I know there is a lot of clinical studies investigating chemo induction and conversion strategies also in the unresectable stage 3 disease, but it's something that is not part of our clinical practice. So in our clinical practice today, patients with unresectable stage 3 should be candidated for a concurrent chemoradiation followed by immunotherapy. So it's very important to discuss all these patients.
What are your thoughts here, Dr. Hassan?
So in this issue, our experience is a little bit different because I have some patients who there is a study. It's called MDT Bridge trial, if you know it.
Of course.
So we are using I used the MDT Bridge trial for the patients to downstage them. They were like a 3B patients, and it was effective, and the patient went for surgery. We used to over the past, especially as you said, the MDT is the most important thing in treating lung cancer cases, and over the past like around 2 years, starting mid 2024, I do believe that our surgical team, they are becoming more convinced of using perioperative treatment as a neoadjuvant to give chemotherapy in lung cancer cases. Right now, in our MDTs, 85% of the time, the patients are receiving perioperative treatment before going through an upfront surgery. We have some cases upfront surgery, but our surgeons, they like to give chemo IO before going for surgical treatment in stage 2, 3A, 3B cases.
Now let's move over to the metastatic setting. So we have the Rationale 304, the Keynote 189, Checkmate 9LA, and the Empower Lung 3 that looks at patients with non-squamous, as well as in some studies, squamous cell carcinomas. And you can see the 3-year overall survival at the bottom over there. So, Farooq, the 3-year overall survival data from Rationale 304 actually shows the widest separation in the PD-L1 more than 50%. In fact, Francesco, when he showed it, in the intent to treat population, it didn't show much difference, but it was in that more than 50% where you saw that really, really wide separation, which is actually slightly different from what we're seeing in the Keynote trial and the Checkmate trial. And of course, the Empower Lung 3 did not even report it. So, has this influenced your decision as to what you're going to do in that metastatic setting for that patient who has a PD-L1 of more than 50% here in the Middle East? Are you going to give chemo plus IO versus single agent IO?
Yeah, I think, in my opinion, there are not many patients who you would consider single-agent immunotherapy. I would only consider for those patients with very high PD-L1 positivity, who have, significant comorbidities, poor performance status, not really well fit patients, and low disease burden. Otherwise, the majority patients who have high disease burden, you need a quicker response. Fit patients, my standard will be go for chemoimmunotherapy rather than single-agent immuno.
So, Francesco, you showed data and you actually showed some various pieces of data there. One that was presented last year at ESMO that looked at giving single agent immunotherapy with Pembro versus Pembro plus chemo, and there didn't seem to be much of a difference in that more than 50%. But then you showed analysis that shows that if you give chemo plus immuno, it is better in terms of prognostic outcome compared to giving immunotherapy. Now, putting aside those patients who are frail, who are old, who are not candidates of chemotherapy, in the clinic, what are you going to do? Are you going to give chemo IO versus IO therapy in that more than 50%? Are there clinical characteristics that help you discern, or is it just a blanket rule looking at the data that we have to give chemo plus IO?
Well, this is an actual clinical question for our real-world practice. First of all, just a brief comment on the randomized studies, all the randomized studies presented at ESMO last year. As I said during the presentation, unfortunately, that was a nice clinical design, a nice study design, but the primary endpoint was not adequate, in my opinion, because response rate at 6 weeks is not the best endpoint to evaluate a potential difference between these two treatment arms. And anyway, the enrollment of the trial was terminated earlier because of a futility analysis related to this wrong endpoint. So we have very low number of patients. So the conclusion of the study is not reliable. We cannot translate to drive our clinical decision in the real world. I think the individual patient meta-analysis provide a more reliable evidence from the methodological point of view. A lot of patients, all randomized studies, including immunotherapy and chemo, is an indirect comparison, but it's is good from the methodological point of view. So providing high quality, evidence or mid-quality evidence supporting the higher efficacy of chemo combination in the PD-L1 high populations. Also in terms of overall survival and long-term survival, because if we look at details of the curves, chemo is better than single-agent immunotherapy. So in my practice, if I could, because in Italy we have a regulatory restriction regarding the use of chemo combination also only in patients below 50%, unfortunately. But if I could, from my point of view, chemo combination is the standard of care in PD-L1 all comers, also in PD-L1 high population. I'm confident to use, I agree with Farooq, and I'm confident to use single-agent immunotherapy in specific subgroups, so patients with very higher than 19% PD-L1, smokers, STK11, KRAS, KEAP1, wild-type disease, where I can expect a comparable benefit with chemo with a more tolerable safety profile. So these are the only subgroups I candidate for single agent. Otherwise, chemo is the standard of care in this population.
So, Maroun, what do you do in your clinic?
PD-L1 more than 50%? Yeah, so I mean, I tend more to use chemo IO if the patient has a higher tumor burden, or if they are young and I don't worry about toxicities, at least a couple of initial cycles. So I tend to use more chemo IO.
Okay. Now, if we had tislelizumab available in our clinics tomorrow, where would you position it in your treatment algorithm for early stage and advanced metastatic setting? Khoury, I already have you here, so why don't I pick on you and then I'll pick on Aref.
I mean, definitely, it will be, if it's available. I have to take several things in consideration. The data is appealing in the neoadjuvant, in the perioperative setting. Although I really need to know more about the toxicities. I think if the way it's reported, then I think there should be like a smaller analysis to see what are the toxicities if they are reported the same way as other studies. So, that's the only thing that will keep me a little bit anxious about using the medication, because grade 3 toxicity, like Dr. Farooq said, is 73%, is a little bit scary. But we need more data about, or for example, let's say if we report the toxicities the same way they are reported in other studies, are they gonna match or no? Probably that's the only thing that will keep me from thinking about using the medication. Price difference, I mean, definitely. I mean, this is something to be taken in consideration. If you have similar efficacy and similar toxicity, of course, I'm going to be using the cheaper medication, because we know patients are having problems with these agents in terms of how much the caps on their insurance policies about. So yeah, I would definitely, this has to be a factor. Thanks.
Okay. And Aref, what are your thoughts over here? Where would you position it in your clinic?
Yeah, this is the everyday debate, Shaheenah, in our tumor board, in our morning hub meeting. So whether to use single immunotherapy or dual immunotherapy, whether to use immuno plus chemo, I think it is case by case. It is an individual base, depending on patient criteria, which is like age, comorbidity, performance status, probably tumor criteria, like probably a huge burden of disease. You want immediate response, even more than 50%, you can use chemo immunotherapy. Eligibility for chemo, patient can take chemo. Eligibility for immunotherapy, if has any contraindication. We have patients with severe rheumatoid arthritis, psoriasis that you cannot use. So it's patient by patient. Positioning of Tesla, I think the data is very clear. Response rate is very high. Pathological major, I think it is replaceable, probably due to its pharmacokinetic mechanism. Very important point highlighted by Dr. Khoury. We are in governmental hospital, and we have now a coverage for the mandate that is very limited. So it's not an open mandate issue. So probably price will play a very important role in my selection, especially for the mandate patient at the start, and probably later to expand the use. Thank you.
Hassan?
It's the same answer. I do believe that they covered everything.
I'm sorry I'm interrupting you, Hassan. But
Mm.
can I say a show of hands? If you had Pembro versus tislelizumab, and tislelizumab was cheaper than Pembro, just a show of hands, who would use Tesli? I'm going to call it Tesli now. Farooq, you're not going to use it? And Aref puts a big hand up. So cost is driving your decision making, is it not? Francesco,
Yes.
does it not drive your decision making?
I
For
did
me,
not put my
Yes,
hands up.
Francesco. What are your thoughts here?
yeah, I mean, cost is an important driver. I agree with the colleagues, because all of us need to be taken into account also the cost of the drugs. But I mean, also we have, I think, relevant data supporting the efficacy of these drugs, of this agent in the context of both early stage and metastatic lung cancer. I would like to point out the setting of the PD-L1 squamous non-small cell lung cancer, where this is probably the only PD-1 agent showing efficacy in this context. So is a kind of comparison between the TISLE and the 9LA regimen in this population that we know is different toxicity profile also. So this is something to be also taken into account when we discuss about the potential role of this drug in the treatment of our patient.
So, Hassan, if I can come back to you, very specific question. You have a young man, he's 50 years old, and his PDL is a stage 4 non-small cell lung cancer, adenocarcinoma. PD-L1 is more than 50%. Looking at all the data that Francesco presented to you, including the rationale trial, what would you use? Immunotherapy by itself, immuno plus chemo, and which immunotherapeutic agent would you use? Very specific question.
So, 50-year-old, good performance status, I would still go with chemoimmunotherapy.
Which
Yeah.
immune? You
With
got
immune,
study is, and you've seen the
yeah,
data. Francesco is
I
pretty.
would strongly look from. We are still biased to our personal experience. Our experience with the immunotherapy that we are giving, especially pembrolizumab, is excellent. I cannot say it's not excellent. But with this price, with those data that I have, I would strongly consider giving tislelizumab.
Aref, would you use Tesla or another immunotherapeutic agent, considering that Francesco really took 1 hour to convince you about the hazard ratios and the broad confidence intervals and the separation of the Kaplan-Meier curves? So, what would you use?
Yeah, I'm convinced 100%, but I need more data about the toxicity, as my colleague highlighted. Probably we need to know more.
So, Francesco, we have 4 minutes. And I want to actually touch upon that before going forward, because yes, cost is going to be a huge deal, and that's going to be that'll be something that will drive physicians as to what to use. We're always going to use a cheaper one, but toxicity is also important. And the table that you showed did suggest that the toxicity was slightly higher with the Tesla. So how do you account for that? Because that's what you need to convince Aref now, because Maroon's already convinced. Farooq is smiling away, so he's convinced. So Aref needs to be convinced that it's actually safe to use the Tesla combination.
Yeah, I don't know which table you are referring to, probably the table in the early stage. But
Yes.
as I said to you before, is only related to the different reporting system of the adverse event between trials. Since if you observe the toxicity profile of the drug in the metastatic disease, you can see the adverse events are absolutely in line from what you expect from a PD-1 inhibitors, both in terms of grade 3, both in terms of immune-related adverse events. You don't have significant difference. You don't have relevant signals that this agent has a different toxicity profile as compared to other PD-1 or PD-L1 inhibitors. Indeed, if you will look at the treatment discontinuation, these are absolutely in line across all these studies, both in the early stage and in the metastatic disease. So I'm quite confident that the toxicity profile is not an issue with this drug. It's the normal toxicity profile we can expect from immunotherapies, from single agent immunotherapy. We know very well this kind of toxicity profile. I think the colleagues highlight an important point, that is the experience, the clinical experience with the drug, the opportunity to use to be confident with the drug in the clinic. This is probably another driver of our clinical decisions.
So can I change my voting?
Yes,
Yes, 100%.
He's convinced. Aref is fully convinced. Hassan, you stand up. You have exactly 1 minute.
Yes, so just I have one question because I'm very lucky to have someone from the region. What we are using in immunotherapy right now in a specific medicine that we are trying to give a lower dose. So in pembrolizumab, what we are using now, we don't use the fixed dose with 200. We are using 2 milligram per kg for those patients, and the maximum limit is 200. And we will publish the data very soon, but the data is very similar during the response. Do you have any experience with giving immunotherapy in a lesser dose than the recommended one or no? Just one question, because I'm lucky to have you as a panel with me today.
Not me, but I'm convinced, like you also, I think it's worth to try it.
So let me ask Francesco the question. We did see some data from India that was presented at ASCO and ESMO, not only for lung cancer, but also for head and neck carcinomas, where a lower dose of pembrolizumab was actually just as efficacious. I'm not saying we should do that because it's not standard of care. So please don't get me wrong there. And I'm not saying we should do it for Tesla either. So do not do it. No one out there should do it. But my question to you, Francesco, is what are your thoughts? Do you think in the future we may actually come down on the dose? And that will be the last question because the time is up.
Yeah, I think we will. This will be a matter of discussion in the future because of the limitation of the resources and increasing cost with oncological drugs. So we are discussing more and more about de-escalation. This discussion is in the context of de-escalation strategies, including not only dose but also time of and duration of treatment. We are now discussing about a shorter duration versus the fixed 2 years of treatment. So I agree with you that we will discuss more about this topic in the future.
All right, so we've reached the top of the hour. This has been a fantastic deep dive into immunotherapy in non-small cell lung cancer and a fantastic discussion. I think my takeaway is that we have so many different immunotherapeutic agents that we use in non-small cell lung cancer, both in the early stage as well as in the metastatic. Bottom line, please use it where indicated, where there is no target, where you're supposed to use immunotherapy because it improves prognostic outcome both in the early stage as well as metastatic. It's good to have options. Deep dive into the data. You've seen some of the discussion as to which immunotherapeutic agent you should use and why. I think ultimately it'll come down to cost, it'll come down to side effects, and it'll come down to accessibility. The data for Tesla is very, very impressive. It's the new kid on the block and certainly something that we would consider using in the community. So thank you, Dr. Hassan. Thank you, Maroun. Thank you, Farooq. Thank you, Aref. And of course, our international speaker that's been such an awesome honor to have you on board today. Hope to see you in our region very soon. Thank you, Francesco.
Thank you so much.
Thank you. Thank you. Bye-bye.
All at the next edition of the EIOC Journal Club. Thank you and good night.
Good night.
Thank you. Enjoy the World Cup.
Bye.